Hi everyone, welcome to the latest installment of Phoenix Children's Live. I'm your host today, Peter Ballester. I'm a brand manager with the Phoenix Children's Medical Group. Today we're going to talk cancer survivorship, and we have some special guests with us today. We have Dr. Lexa Walsh, thank you for coming, and also bone marrow transplant nurse coordinator Roxy Ayala. So we're going to be talking about, as I said, cancer survivorship. If you have questions, you can put them in the comments and we'll get to them as soon as we can. Otherwise, if we don't get to it, we will answer questions afterwards, and hopefully we'll be able to get all those questions answered. But for now, we have these two folks live, so let's start off right away. I think the first question, Dr. Walsh, is what is cancer survivorship, and kind of what is it with regard to Phoenix Children's Hospital?
Well, thanks for having us. We're excited to be here with you today. So we have a great program here at Phoenix Children's Hospital. We are part of the Center for Cancer and Blood Disorders, and we focus primarily on the care of patients after they've completed their treatment. Of course, the primary focus of our department is diagnosing and treating patients who present with cancer and other blood disorders. But we want to make sure that those patients stay healthy throughout their lives, and that's really the focus of our survivorship program. There are about 400,000 childhood cancer survivors in the United States right now, about 3,000 in the Phoenix area. So it's not that uncommon, and as we're getting better and better for treatment of these problems, we have more people that survive. So our focus is to keep them healthy throughout their lives.
So the last day of cancer has got to be a big day, a celebration for patients and their families. But it's not the end, is it? And that's kind of what cancer survivorship is about, right? So what happens after that big final day of I've made it through treatment?
Yeah, there's usually a really big party, and families are really excited about that day. But then that's where our teams jump in. So we start seeing the patients not immediately after cancer is finishes treatment, but 1 or 2 years after the therapy is completed. And we have a whole set of procedures in place depending on the type of cancer and the type of treatment that patients received on what we need to be doing to keep those patients healthy.
Well, you just gave me the segue question. So when do you typically know what a patient's post-treatment needs are? I mean, you kind of said that it depends on what the cancer is, how aggressive it was, but kind of talk about what kind of the regimen would be for those patients then.
So yeah, I'll talk about the oncology side, and maybe Roxy can talk about bone marrow transplant patients. But it's really dependent on the treatments that they receive. There are a lot of different childhood cancers, and each of them receives a specialized regimen in order to obtain that cure. So there's 3 ways of treating cancer: surgery, radiation, and chemotherapy. And all of those can cause effects on the kids as they grow up. So depending on what the patient gets, we create an individualized plan for them in terms of follow-up. So if they had chemotherapy that could affect the heart, we monitor their heart at a specific interval. So it's very individualized to the patient, but we also provide a lot of education to the families about what the treatments were that the patients received and what the families themselves can do to be keeping their kids and patients as they grow up, young adults and into adulthood, keeping them healthy.
Yeah.
Same for us. We start seeing our patients once they meet that year mark after transplant. So kind of before that, it's the same as kind of what Dr. Walsh said. Everything is kind of individualized per patient. Some patients, depending on diagnosis, get certain drugs or treatment to cure their cancer, and some of those are a little bit more toxic than others and cause other secondary effects. Mm-hmm. So we kind of know a little bit before that year mark to know what problems this patient is kind of dealing with at that point. And then from there on out, we test different things to, same way, monitor their heart, their kidneys, their liver, their lungs throughout their life to make sure that they're catching any issues that would come up early on, and so that it can kind of give them better control of their future and better quality of life. So yeah, it depends on the diagnosis, and yeah.
I think we'll get to that too. I think a lot of people would be asking about the length of time, and we'll get to that I think in a little bit. But I think a lot of people would want to know, so what type of doctor would someone go to after cancer treatment if there's a problem that arises afterwards again? So is it an oncologist, PCP, or a primary care doctor, or a survivor clinic, or where do they go from there?
That's a great question because a lot of people don't know that, I think. I think your first bet is to hook up with a survivor program like we have here at PCH. And we see patients who've been diagnosed and treated all over the country, and we obtain the records from the treating institution and put together a plan for the families to follow. So even if it's just a one-time visit to us, they can kind of have a roadmap of what they need to be doing in the future that they can then take back to their primary doctor. Okay. Most of the patients end up seeing us in the clinic here at least yearly, sometimes more than that, depending on their issues. And we manage all the referrals to other doctors who need to get involved. We send information to the primary care doctors and work closely with them to provide any necessary testing. It's really amazing, though. I mean, you read through what some of these patients go through, and they look very normal. You know, for the most part, they're doing extremely well, so it's very gratifying. And they don't need a lot of them don't need a lot of follow-up. It's more preventative care to make sure they stay healthy and we catch things early.
So for either of you, who qualifies to be in a survivor program or survivorship program? And then I think you touched on it just before. Do they have to be treated at PCH? I don't think that's necessarily true, right?
So for us, our patients have to have had a transplant, basically a transplant from another person, like a donor. But they don't necessarily have to have been transplanted here at our facility. Sometimes we have patients that have come from out-of-state facilities, and then they are stabilized, and once they come here and they transfer their care here to Phoenix Children's, and then we just take over. So basically anyone that's had allogeneic transplant.
And we should mention too that you don't have to have had cancer to get a bone marrow transplant, so that makes that department a little bit unique. So we do transplants for other metabolic disorders, autoimmune disorders, and bone marrow failure that aren't classically considered cancers, but they still receive a lot of therapy and need follow-up care.
So when does someone start a survivorship program? Is that different for everyone too, as well? Is it a year, or is it 2 years, or what's the kind of the start time for that?
You want to answer that?
That's okay. Yeah. I know for VMT it starts right at a year. So let's say they have their transplant day 0, then you basically count from day 0 at 365, like that first year. That's when they start their first survivorship, and then it's annually for hopefully the rest of their life is the goal.
Okay.
And being a survivor doctor, I think we should start thinking about survivorship at the moment of diagnosis for things like fertility preservation and picking the least toxic chemotherapy agents. So we have a 84% survival rate now for childhood cancer patients who present to us, which is awesome. So we really need to be thinking about long-term, even at the beginning of therapy. So picking agents that might have better toxicity profile and thinking about the long term. But then our official survivorship program starts at 2 years after the completion of therapy. So they follow with their primary oncologist, and those visits are mostly to monitor for the cancer potentially coming back. The risk of that really goes down at 2 years, and then they kind of graduate to our program. When we start following them at that point, at 5 years off therapy, they don't see their primary oncologist anymore. They just follow with the survivor program.
Okay, so it kind of tails off a little
bit.
Okay.
Exactly.
That was actually my next question too. So reoccurrence is the bad word here for that we all, that you guys in your world. So
Absolutely.
So the question is, why is a survivor monitored? I think it's for reoccurrence, but what's the numbers around reoccurrence, and I'm sure that goes into why someone comes in at a year, 2 years out, and then the 5-year mark. I mean, is that kind of what we know at this point with cancer and the reoccurrence rates?
Yeah, and it's very it differs a lot based on the type of cancer and the stage of diagnosis or the extent of cancer diagnosis. That plays a big part into it. We know a lot about the genetic basis of cancer, and some cancers are more likely to come back and things like that. So we just have to come up with something that's a broad guideline for our patients. So after about 2 years, the risk of recurrence for all types of cancer really starts to come down, and then after about 5 years, it's almost 0. So it's not 0, but for most things, it's close to 0.
Is that for pediatric, or is that adult and pediatric?
It's more for pediatric. Okay. Some adult malignancies can recur later, for sure, but pediatric cancers generally come back more quickly. But we have had patients who are in survivorship already and have recurrences. Then I don't think it's a bad thing they were in the survivor program. Right. We just loop back around and hook them back into the oncology part of it.
So both of you mentioned before when we were talking about kind of the side effects, if you will, of kind of whether it be chemo or radiation. So are there short-term concerns after cancer or blood marrow transplant therapies? You both can take your respective areas, but I think that's would be an interesting topic to talk about for a second too. What happens after those therapies?
So I think for bone marrow transplant, we kind of want to monitor early complications that can happen usually within 5 years after transplant, and it can be anything from hormone and growth changes. It could be just issues that come up with educational needs, organ, make sure that their organ health is okay. We want to monitor for anything that any medical related issues that can be related to the type of treatment they receive, whether it's chemo, radiation, or surgery.
Okay.
So bone marrow transplant survivors are also at high risk of developing another cancer. Mm-hmm. And the important thing is that many of those cancers that they develop after the treatment can be treated if you catch them early enough. Yeah. Like thyroid cancer, skin cancers are very common, but if we catch them, we can treat them, and the survivor can go on with their life. So.
Yeah, that's kind of another good segue too. Is people should obviously get regular screening, but what happens when I think maybe there's an education part of it too, that if they've had cancer, they beat it, and then they feel good. I think working with them to make sure that they stay on the regimen of getting tested if they're at the 5-year mark or the 2-year mark. Do you see that that's a problem with kind of, I feel great now, and you don't have to worry about it? That's got to be that's got to be something that we really need to work on, right? I mean, can you talk a little bit about that, or what's the challenges there?
I know that for us it is a challenge because patients, really, they've gone through such a difficult time in their life, that first year of their transplant and diagnosis and everything. So once they start feeling good, they start kind of sometimes relaxing on some of their things that they've been doing to stay healthy. And sometimes when they just feel good, they think, I feel fine, I'm fine, I don't need it. But the purpose of Survivor is to try and catch those medical related issues early before they start to make the person feel sick or have symptoms, because then it gives us a better chance to treat it with the least amount of medication needed and the least impact on that patient, and to keep them healthy the way they've been feeling good. So but that's always hard, especially with the maybe teen population. But
I was going to say that, a lot of our patients are younger when they're diagnosed, and the parents take a lot of responsibility for the medicines and the checkups and everything. And then as they get older and start transitioning out of the home, they tend to, it tends to be a challenge.
That's why teens, make sure you keep up with it. Okay?
But if you can form a relationship with them, right after therapy and kind of grow up with them, that's helpful.
So another big word that starts with R, it's not reoccurrence, but it's research. Talk about research and what we are doing here at Phoenix Children's Hospital and how that is helping our families and our patients kind of get through this, and what we're doing to kind of do some pioneering and going forward there.
I think, that's one of the most exciting things about our Survivor program. Every new patient who comes to our clinic has opportunity to enroll on a research trial. That trial is to collect information from the survivors about the treatments they received and what side effects they're experiencing. And we hope to learn more. We have about 600 patients enrolled already in that database, and we're asking questions out of it, such as, how does iron overload impact the patients? What is the impact of vitamin D on the overall health? And the bone marrow transplant, Kristen Beebe and the bone marrow transplant survivorship, who runs the program with Roxy, they're doing really exciting things even nationally to try and bring that research together and kind of centralize, because most programs only have a few patients who've had X disease. So to try and combine that information and really figure out, this patient who had this type of transplant is at risk for this type of complication. So it's really exciting. We encourage all of our patients to participate and help us out.
So we talked about teens before. Let's go back 1 second here. So when a child is a teenager, and when do they make that transition to adult? Is it just the magic number of 18, or how does that work?
Yeah, no. I think for us with transplant, like we continue seeing the child or the patient until they're past 18. I'm not sure if the cutoff is like 20. It's like
I don't
like
think
20.
We don't have a hard and fast
we don't have
cutoff
an exact number.
Okay.
Yeah, but gradually as the kid gets older, we towards the young adolescence, we try to encourage the child to take a little bit more control over their care, like making their appointments, make sure they're doing their labs, making sure they're taking any medications they're still on, or involving themselves in the community and things that maybe can help them get over certain long-term complications that they've had. But we usually identify an adult facility that can, because there'll be a time where they might feel more comfortable going to an adult center at one point. So then we'll transition their care, and there's a lot of recommendations that we give them along with their primary care physician so that they can continue, these guidelines, what to watch for in the future in their new centers that they're followed up with.
Yeah, we talked about short-term concerns. Are there any specific long-term concerns as they kind of, after their therapy? Or are they kind of the same that we talked about before?
Well, short-term side effects of chemotherapy, you think about, the hair falling out, nausea, vomiting, weight loss, and those types of things. Those really change as you think about long-term. And the interesting thing about long-term side effects is that they probably won't show up until 20 or 30 years.
Wow.
A lot of them after diagnosis. Some of them do show up more quickly, especially in transplant patients who tend to receive more intensive therapy. But there is a need for continued follow-up with those patients. Things like heart failure from cardiotoxic chemotherapy can occur 30, 40 years after the diagnosis. So if you were 4, 30 years after your diagnosis, you're still only 34. So you're still young, in real terms, but you don't, you may not be thinking that, and your doctors may not be thinking that you're at such significant risk of those problems.
Yeah. I think that probably the one question that most patient families would ask after their child goes through therapy and it looks like things are kind of coming out on the good side is there a time that they can ever stop worrying? And I know that's a hard question for the clinical side to answer, but it's probably one that's always weighing on the mind of patients, families. How do you react to that kind of a question when asked by a patient family and without kind of being black or white on it, and that's the hard part, I'm sure.
Yeah, it is hard.
I think we try and tell the families to, I know it's hard for the parents to just we've kind of kept them on guard for so long to watch certain things, and then after a while they just kind of think like that, but we try and remind the patient, you survive this, live your life, as long as you follow up with Survivor Clinic, let us do the worrying, let us do the workup every year to make sure that there are no worries, and that way you can just focus on living your life now and enjoying what you accomplished. But
I think I like to tell my patients, knowledge is power. So if you know what to watch out for and you can be an advocate for yourself, the chances are you're going to be able to live a long and healthy life. If you ignore things and you don't follow up, then it may be a little bit more difficult.
Well, that's I think a good point. I think the key word there is advocating for your own health, especially if you've made it through something as devastating as a cancer diagnosis. What are some of the things that a family or a patient can do to advocate for themselves? Is it kind of those things, those proactive things like more healthy eating, obviously not smoking, things along those lines if it's a teenager? What are some of those things that you would tell a patient or a patient family on how to advocate for yourself going forward after therapy?
Well, one thing is they can always utilize our services. We can help with the advocacy process and kind of, walk them through it. But I think that, there's not anything that we can do to change what already has occurred. So we got them through the cancer. They have made it that far. So really whatever they can do at that point to keep themselves as healthy as possible and not add. So let's say they're at risk for heart problems.
Right.
to not eat an unhealthy diet, to not smoke, to not drink to excess, and get enough exercise. Those are the things that they have the control to change that can really make a difference. So they can have a big impact on their own health and quality of life, and we can help.
Yeah. Well, I think one of the things that I think at Phoenix Children's Hospital is so great as well is the fact that, you know, they come in, and as you said, if there's something that's affecting the heart, we have kind of this continuum of care where there's, you know, so many different subspecialties that kind of can get involved with the kind of the, like I said, the continuum of care. So there's so many experts that can kind of weigh in and get involved in that person's case and understand what's going on, even outside of the initial cancer diagnosis. I think that's got to be great,
and
too.
So I don't think we mentioned yet, we're a one-stop shop for the patients. So it's a multidisciplinary clinic. So patients have the opportunity to see a lot of different people at one time. So it's kind of can save them time. So so in the oncology survivor program, you will see an oncologist, an endocrinologist, a social worker, a nutritionist, and a nurse clinician all in the same visit, plus have your labs drawn. And we also schedule whatever testing is needed. And then for the bone marrow transplant.
Yeah, for bone marrow transplant, we tried, since they sometimes have gone through the treatment for cancer, maybe with Dr. Walsh's side of the team, oncology team, and then sometimes they do have to come to transplant. So their toxicity might be a little bit more intense sometimes, but they will have... we'll do their labs and all their testing ahead of time, scans, labs, special consults that are maybe outside the facility. And then they come to the survivor clinic where all those providers are here. So they'll see the nurse coordinator, they'll see the BMT attending or Kristen Beebe. They see pulmonology, renal, or nephrology, which is a kidney specialist. And they see social work, neuropsychologist, nutritionist, and we're working on having endocrine as well.
I love that you brought up the nurse psychologist too, because I think there's a mental part of beating cancer as well. I think that it's not brought up enough. I think that you have to have this kind of not woe is me approach to it, and I think that the nurse psychologist can be a huge help in that. Can you talk a little bit about how that person would work? Because I think that person it's not as the clinical, but I think it's a great opportunity for families and the patient to be able to kind of learn what they're going through, what they might be feeling going on. Can you talk a little bit about that?
Well, it's really interesting taking care of these patients, because one of the most common complaints that we see are not physical. Patients often struggle with education, school, and then depression, anxiety, all of those things too. Our number one diagnosis that we treat and follow up in our center is leukemia. And for treatment of leukemia, you need to have what we call intrathecal chemotherapy. So chemotherapy that is directly into the fluid surrounding the brain and spinal cord. That does cause long-term side effects in terms of making it a little bit more difficult for those patients to do well in school. So having neuropsychological testing to really figure out what are the strengths and weaknesses of each of those patients, as well as counseling, is super important and can be an integral part of the team. And in bone marrow transplant, they actually will do neuropsychological testing before and after the transplant. So you can compare and see what's happened, so you can address those issues. So it's a huge component. We hope to even strengthen that part of our team even more in the future. I suppose any kind of treatment for cancer, I mean, it's got to be kind of a long road. So if it's a child that's in school age, I mean, that's pretty tough. We do have one darn cool school, which is great. But I mean, that's a long time to be away from the studies, and I suppose that can be a problem as well too.
And some of the, like she said, the treatment that they receive can sometimes cause issues in the child's development later on. They might have educational needs that, like, maybe a child goes to school and they didn't know it before because they weren't in school, but now they're in school and their mom's starting to notice that they're having a little bit issues with keeping up with the classroom, or they need just a little bit of more accommodations in the classroom or extra help, to kind of keep them at their pace and along with their peers. And the neuropsych testing helps a lot with identifying those problems and where they need help and how we can help those children.
That's great. So I think kind of the closing question here would be, how can someone get a hold of us, and where do they go if they want more information or they want to get into cancer survivorship at Phoenix Children's?
Yeah, well, as we mentioned, if you were treated for cancer here, you're already going to be integrated seamlessly into the program. But if you were treated for cancer at another place, anybody who is treated for cancer starting at 18 years or younger is eligible to come to our program. Okay. And you can call our main CCBD phone number, which is 602-933-0920.
What is it again?
602-933-0920. We'll put the number below. See, I'm an expert now. And you can ask to speak to our survivorship coordinator, and we can request the records and help get you a follow-up appointment in our multidisciplinary clinic. We'd be happy to see you.
Excellent. Thank you guys so much for doing this today. We really appreciate it. Again, if you have questions, you can put them in the comments. We'll get to you as soon as we can. We appreciate you tuning in to our installment, and we'll see you very soon. Thanks, everyone. Take it easy.